Good afternoon. This is Dr. Mark Sarkell, the Chief Medical Officer of Meritage, giving you a somewhat streamlined and updated webinar on the risk program, HCC coding, and how to document correctly. Many of you have seen much of this, but refreshers, I think, are always helpful, and we've learned a few things along the way ourselves. So first, to review the definitions in this battle, RAF is a risk adjustment factor which estimates a population or a patient's complexity and thus expected cost to the payer. And these RAFs are basically derived from Medicare claims and cost analysis that say that people with atrial fibrillation cost more than people with coronary artery disease, for example. HCC is the hierarchical condition category, which are those diagnoses that comprise and add to the RAF. Many things don't, such as asthma for Medicare patients, coronary disease, as I mentioned, for Medicare patients, but many things do, as we'll go over. So the HCC code is the primary driver of the RAF score, as well as demographics for patients and population. Properly means that every single year we at least one time assess the diagnoses that are attached to ACC with stress and plan in a way that auditors will not find fault with what we do. If you've assessed somebody's status of amputation in 2017, Medicare believes that the amputee toe grows back unless in 2018 you say status of amputation, wound continue dressing changes. Patient is the sum of the RAF plus demographic factors adjusted so the mean is 1.0. Thus 1.0 is more or less the average RAF across all the categories, let's say in Medicare or in a commercial risk program that we'll talk about. And finally, payment. Yet there are payments based upon 992 and 3s and 4s and so forth, but the group or physician group has substantial upside and downside based upon the RAF score. Now here's an example. The dashed line shows an adjusted risk score and adjusted risk score, which is a corrected risk score, basically unity. So that if you look at 1.0, on the x-axis, it goes to 1.0 on the right axis. The solid line shows a lot of deviance from this idealized comparison. And what that tells you is that for the same diagnosis, people in St. Paul, Minnesota are coded more intensively and get more money as opposed to Miami, Florida, and McAllen, Texas. So there's a problem with RAF in that physicians have various coding intensities, and those intensities are rewarded by the payers. So in this graph, the purplish areas, where I think people voted for Trump, code very well. They get somewhere between 5 and 15% more reimbursement than average, whereas the purplish areas, such as California and most of New York, most of Florida. So there's a difference between what we're paid by the payers compared to what someone's paid in Minnesota of about 20% for the exact same work. How to fix this? We fix this by really committing our bodies and souls to identifying HCC codes and RAF. So what risk adjustment does is defines the price that insurance companies and payers pay based upon documented risk. The other was assessing based upon risk factors, demographics, occupation, and setting price. This is actually a better way of charging and rewarding for insurance payment. So what it really does is levels the playing field from one practice site to another practice site. If your site has a RAF of 1.2 and mine is 0.8, you should be doing more intensive services, you should be using more resources, and you should be paid more. This also identifies patients who might benefit from case management or outreach because it's a good marker of complexity, And again, the higher score, the more revenue for the physician group. So Meritage is done. In 2015, we started the program with our RAF score of 0.69 at $2.5 million on our 5,000 scanned patients. Not sustainable. We started the program in 2016. We broke even by raising the RAF score to 0.85. We were moderately happy. And here, we think we've actually made money on the scanned population of 2.5 million, which means also our partner hospital will get some money back. And when we can hit the Medicare average by 2018, which is 1.0, and have a little bit more upside. Again, around these patients are maybe a little bit healthier than across the country, so we may not hit that, but that is our target. What to do with these programs and these educational access is to take the documented risk, which is the blue cylinder, and add to it the actual risk that you are already providing care. The actual risk, we'd like everything to be the dark blue, so we're capturing all the conditions that determine the payment from the payers. For example, if you look at Esther, who's rich right now, if you look at her demographic risk factor, it is 0.815 there on the right side. So if we can document anything clearly, the group would get, I could have this out, but it's about $2,400 for her, for care for her, because she's basically pretty old. However, if we document her medical conditions, including systolic heart failure, major depression, and more importantly, functional quadriplegia, if she is functionally quadriplegic, we'll end up with a total risk factor of 2.3, which is about 1,000 reimbursement. So there's a $5,000 difference if we document what we do. I was here for a minute and go over again how we should document so that when an auditor looks at our charts, they're visible. So if you look at the right, you make diagnosis, which is sufficient if in your electronic record or paper record you have the code or the diagnosis. And then most commonly it's a previous diagnosis and you identify the status. Stable, worsening, improved, whatever, and you give your plan. Continue current management, escalate therapy, refer Dr. X. That's how you do it. It can be that simple. In new diagnosis, instead of status, you put the logic as to how you made the diagnosis. So, for example, we'll go over these in the next slides. So there's three components. You make a diagnosis, and we will help you identify these, so you don't have to stress about this. These will be available in many different forms, we hope, on the net, faxed, or in task if you're on Allscripts. Then you say you came to the diagnosis and what you're going to do about it. So a diagnosis you probably have not been making, at least until recently, is abdominal aortic atherosclerosis. Logic is we saw it on ultrasound, and your plan to recommend aspirin. Imaging diagnosis will help you determine the highest level of specificity that could make this an ACC code. For example, depression does not count, but if someone has major depression or major depression, which is what we take care of in primary care mostly, that counts as an ACC code. Then you give the stress or value statement, how's the patient doing, and then what you're going to do about it. So you write mild major depression, stable clinically, continue SSRI. And again, we'll feed these to you at the appropriate times, but it's good to get good at this. So here's an example, pretty good to do it, and you see is the problems on the top and the plan on the bottom. This is actually how I was taught. So number one, asthma COPD overlap syndrome. By the way, asthma in the medical population does not count as an HCC code. In the commercial WHA population, it does. Go figure. So here the physician The pulmonologist gives his logic. P suggests moderate asthma with a fixed and reversible defect. That's how you make the diagnosis of the overlap syndrome. And you go to plan. He says, Dulera twice daily, rinse mouth, administration demonstrated, use role for symptoms of wheezing and shortness of breath. Problem number 2 that's new is cough. He gives his logic due to asthma and postnasal drip, and the plan is to use the regimen for ACOS. This is another new problem, presumably from inhaled steroids. And the plan is to rinse your mouth after Dulera, consider ENT evaluation, and final problem, postnasal drip. He gives a status of improved and said add nasal rinses. The problem is sometimes the numbers on the top and the bottom don't line up. An auditor who really doesn't have our best interest at heart might not see this, might not make the connection. So I kind of would recommend to you doing everything all at once. You make your problems, you give your assessment and plan. So J44.9, asthma COPD overlap syndrome. EFT suggests moderate asthma with reversible defect. Use Dulera. Cough, asthma, and postnasal drip. Use the same regimen. Dysphonia, probably from steroids. That's your logic. Rinse your mouth. That's your plan. Post-drip, old problem, improved. Plan, nasal rinses, and maybe Benadryl. Some short documentation examples. Metastatic breast cancer to liver, worsening end-stage disease, discuss palliative care. That's a previous diagnosis. But if you just take the diagnosis of metastatic breast cancer to liver, seen on CT, plan the oncologist to evaluate. I think most of this, the counties know very well that senile purpura is the most important diagnosis in the U.S. Turns out the RAF, the C value for that is about 0.23, so it's worth about $700 per year. Noted on them due to age, actinic damage, and aspirin, patient reassured. Again, just talked to dermatology, and they said actinic damage was the primary cause. Secondary hypercoagulable state, many of you are now diagnosing that. If the patient has persistent fibrillation or flutter, you can set it's additional payment, and you just write due to AFib, continue Coumadin. Diagnoses, atrial fibrillation. This is very common practice. Rate is stable. Continue the strategy of rate control and anticoagulation with beta blocker and Xarelto. As much as you want to write it down. CKD4, I didn't know this until I started giving these talks, but that eGFR less than 30, noted twice over 3 months. So your plan is continue good blood pressure control, avoid NSAIDs, get a real ultrasound. If it's established diagnosis of CKD4, write whatever you want. Stable serum creatinine, advised to avoid NSAIDs or monitor follow-up in 3 months. For stable problems, the pithiest way to write this is stable, continue current management. And that counts right now. It is passed by auditors. I try to avoid this because I like to know what I thought when I see the patient again, but this is perfectly acceptable. With almost everything links to an HCC code. So CT3 is not an HCC, but if it's associated with diabetes, it is. Cataracts alone are not HCC code, but if associated with diabetes, it is. A neuropathy, same thing, with peripheral disease. Dyslipidemia, every diabetic virtually has dyslipidemia, so I diagnose diabetes, and then I diagnose dyslipidemia associated with diabetes. And then ulcers, gangrene, and erectile dysfunction. If you don't have diabetes, erectile dysfunction is not considered high value, but if you have diabetes, erectile dysfunction, then of course it is. We do cataracts. Diet code E1136 that will feed you diabetes, type diabetic cataract. Now this will often be missed by the ophthalmologist, so just write cataract problem number 1, diabetes number 2. But you do your review, we will link them together so that we get recognized for this more difficult problem. The plan with Dr. I visits. Hyperlipidemia, diabetes with hyperlipidemia, E78.5. Aspirin plan, LDL suboptimal, increased lipitor. Erectile dysfunction, again, they're linked in 11.69 and 52.1. No improvement, try Cialis. As I mentioned before, I find it easier to have a separate diagnosis for diabetes type 2 because we're not doing a wellness exam. I may be just looking at their diabetes independent of the complication. And that's how I put it down. So type diabetes, A1C at target, which is okay for internists. Based on recent ACP guidance, not for endocrinologists apparently. Continue metformin and lifestyle efforts. Is something that we miss frequently because we just write depression as a diagnosis or major depression throws us off. But the definition of major depression is either on medications or a PHQ 9 of 5, which I would say half of us listening to this web have. So depression is a pretty low threshold. And you have a RAF of 0.33, which is pretty good, about $1,000 per year for documenting that appropriately. And various kinds of flavors of depression that can be will help you choose the right codes, and then future visits are much easier. Alcohol dependents are also undercoded. Someone who was a drinker 30 years ago and is still sober has alcohol dependence in remission. And you can see it's worth 0.4, which is about twice as much as atrial fibrillation. And, patients don't like this necessarily, but if they're on chronic narcotics for pain, I often and usually code opioid dependence uncomplicated. And, of course, the patients will see this and say, I'm not an opioid-dependent person, and I'll say, yes, you are. We should really prescribe you naltrexone. You're on 2 hidden BID for the past 2 years. And dose, but you are actually dependent on it right now. And then they see why this has to be documented. Codes in general medicine that we often miss, I've talked about a lot of them. Purpura, secondary hypercoagulable state. Angina, I haven't mentioned. If someone is nitroglycerin, they have angina. It may angina inactive, but they have angina. If you're not having nitroglycerin because they've just had a biopsy doing fabulously, then they don't have angina. But the fact of prescribing nitroglycerin counts. Cancer with metastatic sites separately coded. This is very, very important. Oncology, I don't think we can rely just yet. Breast cancer is one diagnosis. Breast cancer metastatic to liver is a second diagnosis. Don't put it all into breast cancer. We lose about 2 points for that. Stroke primary care diagnosis, but late effects of stroke are, and if it's hemiparesis, that's an HCC. Late effects of stroke, dysarthria, or visual cut, don't count for HCC. Obviously, document them if they're there, but they're value. That I did not diagnose in the past is status of colostomy or amputation. There's a real code for this. Stump well healed. Look at the feet. It would be a nice way to document that. So every year, a diabetic who lost his first grade toe, he will diagnose status of colostomy just one time per year. Functional paralysis due to Parkinson's, multiple sclerosis, advanced dementia. And what does that mean, functional paralysis? It means you need a couple of folks to help transfers, and people who are mostly chair or bed-bound or wheelchair dependent. Atherosclerosis on ultrasound reports comes up frequently, and pretty much atherosclerosis everywhere but the coronary is an HCC code. We talk about depression, secondary pulmonary hypertension is often left out. Look at the echo reports. Substance abuse we talked about. Thrombocytopenia, some people have platelets of 140, 130 for no reason, or maybe they have myeloproliferative syndrome or hyperplanism, documented once a year. Finally, carotid artery disease found by one of our cardiologists is an HCC code. Stenosis and atherosclerosis of the carotid is not, but carotid artery disease is. So that's my go-to diagnosis if someone has carotid narrowing. So we work together on this to do as well as possible to be able to maintain this group of population as our patients and in our partner hospitals, and really the RAF is absolutely critical. So the RAF determines what Meritage and in general will get paid for the risk care of these risk patients, and either the skin patients, but the WHA patients also in a risk program. And that determines our financial viability, bonuses, and ability to maintain these insurance groups. So we have programs to help make this happen here at Meritage. The first is risk adjustment program, which I've been talking about, and secondly, the wellness at home. First, these are the risk patients, the Medicare Advantage plan, where we can lose or make money depending upon how well we utilize resources, and more importantly, actually document the intensity of care. And I think you're pretty familiar with this by now. Patients, your staff advises us when the patient is scheduled for a wellness visit. I think we can get this data from Allscripts. You don't have to do it if you're on Allscripts. Then our coding specialist completes a pre-review and sends us like tasks, fax, email, post it on the internet, and maybe carrier pigeon next year. So that may be very helpful because if you don't have it, you can have your MA just pull it from the internet, right there when you're seeing the patient. Look at your form and see if those diagnoses make sense. If so, code them. If not, just tell us that they're not, and if so, why, and we'll take them off the denominator. And our specialists will do a post-review. If you have 80% capture rate, you qualify for the incentive bonus of $200 for each one of these patients. So if you have patients, that's a $10,000 bonus. And of the physician groups, not all of them, passes right on to physicians. So an example of a chronic conditions review, I actually found it a little hard to read, but on the side you see the possible diagnoses, such as diabetes mellitus, the source where the coder got it from, a diagnostic report, previous claims, and what the recommendation of the reviewer is, which is assess and document. Independence, uncomplicated, the reviewer comments, is the patient still drinking? I think this is a title here. If no, she's in remission, and document that. Functional quadriplegia, the review asks, is the patient immobile due to their disability? If yes, you code it. If no, just let us know. No, we'll take it off the list. And finally, non-thrombocytopenic purpura is senile purpura. And here's one we kind of force the diagnosis a little bit. Anybody who's on the old side on aspirin, we expect to have it. And certainly take it off the list if they're not. Just remember to code it once. Now, we've had a pilot program in Marin where we put these diagnoses into the active problem list so that you don't have to transpose them from the condition view or MIPANET or a task. Sometimes some docs love this, some hate it. We'll probably institute it if it's approved by the quality committee, and if you need it, tell us and we won't do it for your folks. So here's a view that the coder then does. She'll take a look at your plan, and you'll see here that the diagnosis was recorded when she did the post-review. The alcohol dependence uncomplicated was not coded, so you got a no there. Quadriplegia was maybe mentioned, but there's no documentation that the patient was functionally quadriplegic or wheelchair or bed bound, so that didn't count. And non-thrombocytopenic purpura, the diagnosis was not active or was resolved, so this was taken off the denominator. So this person got 1 right out of 3, unfortunately, won't get the bonus. The other group, I don't want to confuse you too much, that's new, are WHA patients that are also risk. These are commercial patients, so they're under 65. They tend to be a lot healthier. So we identify, what we do is identify who we think is high risk based upon previous claims, or what WHA tells us, or a questionnaire they filled out. And then at the top 20% of these patients we consider high risk. We provide risk-adjusted conditions in the same way. You document appropriately, and then you get $100. These are fairly simple. Usually they have one or two diagnoses, so we trust we'll just do it, and we'll give $100 for these visits. It doesn't have to be a checkup. A lot of WHA patients don't like coming to the doctor because of their high deductibles, so anything you can cash these folks is great. Despite all this, if you agree or support the Wellness at Home program, this is a program where our advanced practitioners, I think that's the right term, APCs, go out to the patient's home, they evaluate the patients, and they capture the HCC codes. And you can do this if you're busy, if you hate this lecture and think this is all bad, or send these mid-levels out if your high patients aren't seen by August. So we preview. The middle will let you know if she or he finds anything serious, send you a note to be included in your record. What I want to tell you is that there is bonus to you of the $200 for this, but getting 50% of your WHA patients seen at a wellness visit, or your 50% of your risk patients seen at a wellness visit, is a gateway metric to getting the incentive bonus in 2018. That you have 40% of your wellness visits done, you're not getting the incentive. But if you have 50% or more, most of you have 70s to 80s, you will get the point system, which would be about, I don't know, $3,000 or $4,000 for this stuff next year. So in summary, or summary points, the RAF for WHA patients is 20% lower than the rest of the state. And we're only pre-reviewing the high-risk patients. For SCAN, we're reviewing all patients. For both patients, you'll get a list of potential HCC conditions. We would like you to document appropriately during any visit, and you get a $1 bonus for an annual wellness visit for SCAN patients, and $100 per patient for any visit for WHA patients where you attempt to capture the high-risk conditions. Okay, so I think you may have seen this last year. Just think how this lady who is 82, wheelchair-bound, rheumatoid arthritis, chronic fibrillation, and a pacemaker with a PQ9 of 10. Her medications include metoprolol with Xarelto, sertraline, and methotrexate. What HCCs do you think are likely based on your knowledge and experience? There's only one that's really kind of tricky. She's on methotrexate. She has RA, so RA will be one. She's on sertraline and has a high PHQ-9, so she's probably majorly depressed, which could be depression. She has chronic fibrillation, so that's a diagnosis. She's in a hypercoagulable state because chronic fibrillation, and she is functionally quadriparetic because she's in a wheelchair. So there's a lot, and I think all of those here except for, oh yeah, Serial Purpura will suggest, just because she's old and on Xarelto, that may not be the case. And she has sick sinus syndrome. This is a little complicated, but if you have a pacemaker but still require a beta blocker, it means your sick sinus syndrome, your tachycardia syndrome, is still being treated. If sick sinus syndrome or a pacemaker and you're not on a beta blocker, then that's a resolved problem. You no longer have it. So she's on a blocker, and so we will code that as well. So her total normalized RAF is 2.83, which means that we get $10,000 per year for caring for her, because the expectation is she is pricey to take care of. So bothered with this for the following reasons. We're doing care, but need to get financially recognized. And the type of documentation that I outlined for you will be required by all insurance companies within the next several years. If we know the scores of people, we can have our case managers reach out to those with very high RAF. You'll see when you do this, you'll find some conditions that were previously unrecognized. And this is an opportunity. I actually recognize the primary care physicians. Again, if you have 30 Meritage patients in the risk program, and some people are getting bonuses of over $10,000. And last year, to me, I'm an old dog. I have a crowd. Rex tried to remain focused. Still, he couldn't shake one nagging thought. He was an old dog, and this is a new trick. This new trick we can master. It's less onerous than a lot of the stuff we have to abide in primary care, and I think for your personal benefit, our benefit as a group, and patients' benefit, that we can still make enough money to care for this group, I would recommend that you try to master this. If you have any questions about this, feel free to contact Jess Barbier or myself by email, and we'll help out any way we can. Thank you for your attention. Put it on this.